Good morning, everyone. Thanks for coming. My name is Keith Humphreys. I'm the faculty chair for the advisory committee for the Stanford Health Policy Forum, which is a program of the Department of Healthcare Policy that brings us together a couple times a year to talk about healthcare, health promotion, and have a chance also to exchange with leading experts in topics of great interest, which I think we're certainly going to achieve today. I just start with just two anecdotes about today's topic of vaccines. I was in South London about 10 years ago to visit friends of mine who had just had their first baby. And I was talking to them. They had a beautiful 2-week-year-old, and it was a beautiful day out. And I said, why don't we just go for a walk in the park? And they said, no, we're not going out in the neighborhood because there's a very high rate of people not being vaccinated. And of course, our baby can't be vaccinated yet, and we don't want to leave the house. And I remember thinking, well, it's new parents, first time, kind of anxious and all that. But when I went back to my house and looked up, they were in fact correct. Right in the middle of a modern Western city, there was a spot that they lived in where an extraordinary number of people had decided not to get vaccinated. That's one story. Second story, I was talking to a friend of mine from Ghana recently about the arrival of the malaria vaccine in West Africa and the lines down the street for people desperate to get malaria vaccines. So we have at the same time people getting access to vaccines for the first time who are delighted, who can't wait to get there, and then we also have a population of people who had access for a long time deciding they don't want to get vaccinated. So this is clearly more than an issue of just what the randomized trials say or what the journals say. There's stuff about culture, there's stuff about trust, there's stuff about relationship that we're going to get into today. Before I introduce the speakers, I just have a couple ground rules. One, just to say everyone only speaks for themselves, so no one is speaking officially for their university, their medical school, their hospital, or anything else. And second, Stanford University recognizes and values the rights of individuals to express their views, and for that reason, we do not permit disruptions that interfere with the effective conduct of today's event. Freedom of speech is a core value at Stanford University, and our goal today is to foster a respectful space for the exchange of ideas. Individuals who disrupt the forum will receive a warning, and if that warning is not respected, they will be asked to leave. There will be, by the way, time at the end for questions and answers for anyone who wants to do that then, but not please during the panel. So now let me introduce our very distinguished speakers. I could spend the entire time just reading their resumes because they are absolutely amazing. But I'll start here on your left with Dr. Lee. Dr. Grace Lee is the Chief Quality Officer and the Christopher Dawes Endowed Director of Quality at Stanford Medicine's Children's Health and at the Packard Hospital. She's also Associate Dean for Maternal and Child Health. She's done a great deal in this area. Just to list a few things, she served as a member of the Institute of Medicine Committee to review priorities in the National Vaccine Plan. She served at the National Academies of Science, Engineering, and Medicine Committee on Vaccine Research and Development Recommendations for Advancing Pandemic and Seasonal Influenza Preparedness and Response. She was previously the chair of the U.S. Advisory Committee on Immunization Practices that recommends vaccines for the U.S. population. She's also an elected member of the National Academy of Medicine. Next to her is Dr. Heidi Larson. Professor Larson is a professor of Anthropology, Risk and Decision Science at the London School of Hygiene and Tropical Medicine, which you all know is one of the very best public health schools on earth. She is the founding director of the Vaccine Confidence Project, and her research focuses on managing risk and building trust from trials to delivery and building public cooperation, particularly in times of emergencies. She's won many, many prestigious awards. I'll just tell you two from the same year, 2021. The British Broadcasting Corporation named her as in the top 100 most influential and inspiring women on earth. She also won the Edinburgh Award for Science in that same year. Anyone has a year like that, that's more than I'm going to achieve in my whole career. Very impressive. And then doing our interviews as usual is Paul Costello. Paul had a long and distinguished career in politics from the White House through governors and mayors and then running communications here at Stanford. We're very lucky that he's stayed affiliated with us in our global health program and that he continues to facilitate the forum. So I'll turn it over to you.
Thank you, everyone, for joining us. When we thought of this subject 8-9 months ago, it wasn't very controversial, right? And today it's still not controversial. So I thought interesting that we're going to pursue vaccines and public health in an era of distrust. And I want to start with asking each of you, how did we get here? Vaccines used to be like chicken soup, right? I mean, there was no, I remember as a kid standing in line, getting handed a sugar cube for a vaccine for polio. And there wasn't any thought of not doing it. There wasn't parents. How did we get to the current place we are today? Distrust, hatred, this political divide. How did we get here?
I feel like I can't have a short answer to that question. So I'm going to just try and make a couple of points and hand off to Heidi, and maybe we can continue the conversation. So I think a couple of things. There's been a lot of talk about how the COVID-19 pandemic perhaps exacerbated some of the concerns and the trust around vaccines, and that is certainly true. I would say it started well before that. As we all know, that there have been concerns about the safety of vaccines. And I will just make a comment that when I talk about safety, I just want to emphasize safety is really the balance of benefits and risks, and everything should be placed in context. So it is not the absence of any side effects, but rather the balance of the two. But to get back to context, I think there's a couple of things. One is that we have typically taken for granted that prevention is incredibly important, and that it makes sense for it to be valued over trying to do the intervention at the end. But the way we're constructed currently, we're not incentivized to focus on prevention as the opportunity. So that's one thing.
Let me ask you a question right there. Is that because the public health system in the U.S. is so fractured? Is that one of the reasons there's no coordination between the public health system?
Well, there's multiple ways to answer that. I mean, I think that there's obviously the way we're incentivized financially is really not around prevention, not around primary care. It's really around treatment and acute care sort of support for the things that we can see in front of us. When you don't see measles cases or when you don't see airplane crashes, you're more likely to only see the sort of tip of the iceberg. What you don't see is all the effort that goes into protecting patients, and I could say the same for patient safety. All of the effort that goes into that actually is 95% of the work, and making that invisible is our job. But it also means when people can't see it, can't feel it, can't experience it, it feels like a theoretical as opposed to something that's really important and valued to do. And just the way that our current health system in the U.S., although I'm very much looking forward to understanding how other health systems work, primary care is not, prioritized. The time that we spent is much more about the transaction and less about the value of the relationship. So I would say, in an ideal world, it would be amazing to have a society that actually places the value and the emphasis around building the trust and the relationships that need to happen. So over time, as we become more transaction-oriented, we've sort of lost some of that. So that's one part of it. There's another part that I'm happy to go into, but let me just mention it really briefly. A colleague of mine actually pointed out to me something called the fairness doctrine, I think is what it's called. And that was put in place, I think, by the FCC around 1949. And it actually got rescinded in the Reagan era around 1984-85. And what it did is it required broadcasters to provide information about issues of the importance that were important to the well-being of the population. And it actually required that contrasting views be presented. And that was in the era of the old networks that we used to have and our old-style news. Social media was never part of that. And obviously, since it ended in 1984, 1985, I would say what we've seen is a polarization over time where you start to hear one view and you get tunneled into that view pretty easily because there's not that requirement to really present a balanced opinion. So I think those two things for me fundamentally set us up for where we are today.
Heidi, what do you see on a global stage?
Yeah, on a global stage, one thing I've learned is parents don't see the world through risk and benefit. They do actually a much more scientific approach, which is to compare apples and apples, which is risk and risk. And they look at the risk of the vaccine and the risk of the disease. And as you say, they don't see so much of the disease. But I think it's kind of it's that and beyond that and globally, Wakefield certainly put the fright around the globe with the suggestion of autism and MMR. And what was fascinating to me is because the whole autism angle on the MMR piece coming from the States was thimerosal. It wasn't about an MMR vaccine. And somehow he threw, to me, what was going on is that people were all searching for why kids were getting autism. And they came up with very different things on other sides of the ocean, but what they had in common was a search for something else. And I think one of the things with this trend we're seeing is we really need to listen to what parents are looking for, because sometimes it's not specific to the vaccine. It's about, actually, we really want to know what's causing autism. And in other places, it's other reasons. Globally, we have absolutely seen a dramatic shift in public confidence going through the floor, frankly, more in some places than others, way more global than even I expected. I was leading UNICEF's, the team that launched Gavi, the Global Alliance Vaccines and Immunization, and also I was sitting in UNICEF because it's an alliance and they didn't have the secretariat they do today. And for UNICEF, leading the introduction of new vaccines globally. That was between 2000 and 2005. And that's when I, from my perch there, started to see, I got the nickname, the director of UNICEF's fire department. And this was, I'm talking like 20, 25 years ago. We got so many calls from our country offices around the world saying, we got a problem. People aren't taking X vaccine or Y vaccine. And I would go into these countries and sit with the team and see what was going on. And after we kind of put the immediate fires out, I would ask them, when did you start to hear that rumor or start to sense? And sometimes it was weeks, months, sometimes even more than a year before, but they thought it was like just a rumor, it would go away. And that's what inspired me to start to bring some attention to this within UNICEF, and we started some work on trust building, but I really didn't have enough time in my day job to be spending the time I wanted, which is why I went back to academia. But the other thing was that the big question everyone was asking me was, how big is it? Is it getting worse? This is 20 years ago. And I said, we don't really have a baseline. To me, having worked in UNICEF 11 years, there's a lot more anecdotal things we're hearing, but that's when I realized we needed some kind of metric and founded the Vaccine Confidence Project. So we have data, global data, both through social media monitoring, online news media monitoring, and nationally representative surveys. With the confidence index we developed is about confidence in the importance of vaccines. Do they matter? Are they safe? Are they effective? Do they work? And are they compatible with my beliefs? We ran a lot of questions, but those 4 were the most predictive of people actually taking a vaccine. So we've been running that since 2015 globally, and we've been watching ups and downs. You can go to any country on our website and see what they had in 2015, 2018, 2023. And we saw that Europe was the most skeptical in the world. I was pretty surprised coming from the States, but I think if you disaggregated the states, the US into states, it would look more like Europe, with some much more negative than others. France won the Global Prize for skepticism, and if people would say, yeah, they're French, of course, But what was interesting with the French is that sentiment. The thing that wore down the trust was not really about vaccines. It was about a contaminated blood supply with HIV that they hadn't reported earlier enough. It was about, and also before Wakefield, frankly, it was the mad cow disease that the public felt like, they didn't tell the truth soon enough. So when they came along and then said, no, this is not credible, the vaccine's autism, the MMR autism, they said, well, you didn't tell us the truth about that thing. So it was a growing thing. And Europe, to their credit, started to build a coalition of people working on this topic. But we have been following it over time. And what's been interesting is we discovered this diaspora, a sentiment diaspora that followed language diasporas. Between 2015 and 2020, for instance, all of a sudden we saw that Africa, the French-speaking part of Africa, was becoming more and more and more negative. And that was with the advent of social media. Mm-hmm. You could see if it was in Le Monde in the morning, it would be all over the Francophone press in Africa in the afternoon. So that's a newer trend because we started in 2005, 2010 actually, by the time that's when I left and we got it going. So in 2023, fast forward, 2023, UNICEF does an annual State of the World's Children report, and they asked us, they said, listen, we can't do this. This year's the theme was vaccines, or 2023 was vaccines. And they did a chapter on vaccine confidence and used all our data to show, and we compared the countries we had the full comparable data before COVID and just after. There were 55 countries, and 53 of them had a not insignificant drop. I mean, some of it was serious declines in the perceived importance of vaccines for children. That was a shock to me. I thought safety tended to be the one, but when it came to the most fundamental part, which was importance, that was really a worry. We've been following this globally. Africa has been creeping back since 2022. We're now 2 years later, it's coming back. Asia is wobbling. Middle East is all over the map. And Europe is continuing to go down. US is not doing well. So we're monitoring all of this. So that's at a global snapshot. We're in trouble. And I have a little bit of
Talk about when you and I spoke several weeks ago, you said that the pneumonia vaccination rates in Singapore are down 13%, as low as 13%. Yeah. That says a lot because that is a very regimented country and a very disciplined country. So if you look at the data about pneumonia vaccinations, 13% down, what does that tell you about how the parental issues, all of these stuff around child vaccines is leaching into adult vaccinations?
Yeah, it's actually not down 13%. It was 13%, and I've been reading some other stuff in the meanwhile, in some places 6%. It was fascinating to us that during COVID, because I had seen that, it's funny, we hadn't really paid attention as much to adult vaccines. I mean, we're increasingly paying attention. But in COVID, all eyes were on the oldest population. And we saw that Hong Kong had the worst uptake among older people of the COVID vaccine in the world. Singapore that had pockets of refusers. Now, older in Asia is really old. I mean, they have older, and then they have older, and then they have the super older. I mean, they disaggregate because they have long. We're going backwards here, and they're good. And one of the things is the particularly older ones are still really in traditional medicine. Traditional Chinese medicine is really big. But the other thing, and a lot of them, of the very old ones, didn't really have much basic education either. And they were relying, some said their grandson had shown them something scary on their WhatsApp. A number of them said, I live alone. I got so many problems at this age. I don't need another problem. taking a new vaccine, who would I turn to? I would have said, I don't want COVID disease. You know, give me that vaccine. I live alone. I don't want any complications. But they had through their networks. So that's not the issue with pneumo, but I think what it reflects is that, and it's the same, well, it's a little bit more here, but we don't have that same regular interaction with that age population that we do with little kids in any kind of systematic way. And it is something we're working more on, but COVID really took a hard hit.
Turned down the spigot, basically.
Yeah, absolutely.
I'm just going to contrast a little bit to the US, where I do think that the vaccines for adults has really grown in terms of innovation and development over the past decade. I've actually been impressed with how many adult vaccines, and I'm a pediatrician, so how many adult vaccines we were reviewing and approving over the past 7-10 years. I did want to just distinguish, though, that when we talk about vaccination rates, it's a combination of both access and acceptability. So while I do think acceptability may be a component of it, I feel that in the adult space, access may be a huger issue, at least for us in the U.S. And I say that because, number one, a lot of adults, first of all, you need health insurance typically in order to be able to access vaccines. And with health insurance and through the Affordable Care Act, you can get first dollar coverage for vaccines or other preventive interventions, which is incredibly important. But that has not been historically the case. There have been a lot of gaps where adults have just fallen through the cracks because of access issues. I'll also just say from a opportunity standpoint, at least we know that a lot of children will go in to see their primary care physicians on a regular basis. How many of you have been to see your doctor in the past year? Okay, I'm just going to highlight, it's the minority of people in this room that have done that.
There's a bias in this room, I think.
And these are people who actually probably access the healthcare system. So
It's not a crowd that it probably doesn't see physicians.
So the opportunity to vaccinate in primary care settings is just different. The COVID pandemic allowed us to leverage, pharmacies in a very large and different way than we had previously done to provide access to vaccines, because we knew that people could not always receive them as quickly or in as timely a way as they would like to. So I think that also has been a shift. And I just want to point out one other odd thing about the U.S. vaccine financing system that's perhaps not well known. So first of all, I'll talk about kids. Pediatricians have traditionally been the ones to deliver vaccines. And what people might not realize is that pediatricians, first of all, are amongst our physician colleagues, amongst the lowest paid specialty. And yet many of the folks who are in primary care practice actually have to purchase vaccines out of pocket, figure out how to store and manage their inventory, and then submit for reimbursement. And there have been periods of time where physicians can't even get back the cost of the vaccine, much less the administration fees that go with it. And so it's not been a money-making proposition by any means, and sometimes actually a money-losing proposition. And you can imagine if a small pediatric office, their vaccine fridge goes out and they lose, hello, friends. They lose their entire fridge worth of vaccines and freezer. I mean, that's $50,000 outlay, $100,000 outlay right there that they may not be able to recover. That is very different than any other medical product we consider giving, which is part of the reason that it's really hard for people to continue to provide access in the provider's office at the point of contact. And so that's another barrier to doing this. Pediatricians have historically done this because we want to do the right thing. We want to make the right thing happen. It's just not easy for that to happen in the way that the U.S. vaccine financing system is structured. Now, adults, physicians generally, and I'll put pediatric and family practice in the same bucket, but a lot of internists may not want to have to worry about managing an inventory of vaccines, purchasing it, and worrying about their level of reimbursement. And so a lot of physicians won't have it in their offices, and they'll refer them to pharmacies to access it. In order to bridge this gap, historically in the 1990s, there was something called the Vaccines for Children's program. Have folks heard of it? It's a federal entitlement program that provides vaccines free of charge to any child who's on Medicaid or seen at a federally qualified health center. So does anyone know what proportion of children in the U.S. are on Medicaid insurance? 50. Yeah, 50%. So half of our kids might not have access due to financial reasons if we did not have that Vaccines for Children's program in place. And I would argue that it would be really nice to have that level of access for adults who are either uninsured, underinsured, or our insurance plans that don't cover vaccines, to at least provide access to the vaccines. That's not even acceptability, that's just access. But fundamentally, it makes it very hard to do the right thing.
Let me ask you about measles. How concerned are you that we're moving into it? One researcher recently told me that this fall is going to be a real terrible time in the U.S. for measles. How do you see that playing out?
Well, there are many things that could happen. So I will say, it's been interesting, like as an ID doc, I will sometimes now get called about like kids under 6 months of age, parents wondering if they should vaccinate their kids because they want to go on an airplane or something like that. And we don't have that ability to vaccinate kids under the age of generally under 12 months, but we can make exceptions for those under 6 months if they're traveling to an endemic area. But your question is really around what will happen. I wish I could predict infectious diseases, because if I could, then I probably would actually also invest in the lottery. But if I could guess, it all depends on the networks of interaction that will happen over the summer. We know every summer, every family, their summer gets disrupted because your kids are out from school, you're traveling, you're intersecting with different communities and populations. So it depends on that. And then I think it also obviously depends on what our vaccination rates are. So the only way we're going to be able to stop the spread is have highly vaccinated populations. And so if you move back into a school system where there are high rates of vaccination, the impact might not be as great. But if you are traveling and interacting with different populations and then bringing back into the school system in the fall, and the school vaccination rates are incredibly low, then that's the challenge.
So at what you see now, are you concerned? Are you sort of carefully looking at what's happening? What is there a possible explosion down the road?
Well, we've already seen, outbreaks that have been sustained in communities that have very low vaccination rates. And I think the rate of it continues to spread. We're over 1,000 cases of measles now. And I do want to comment that, I think some people perceive measles as a mild disease. We know that there were 2 childhood deaths associated with measles. We know that there are thousands of deaths globally, many more, due to measles from those who don't receive protection. But I think I want to get back to the public health infrastructure. It is so important for us to invest in the public health infrastructure. And I can't say that enough, because that is the invisible work that nobody sees. As an example, it's been cited that for every measles case that we have to follow up on, all of that contact tracing and investigation that has to happen, and testing and making sure that you're having people isolate or be put in quarantine if they've been exposed, is $30,000 to $50,000 a case from the public health system standpoint. And some people think it's as much as $145,000 per case. So in 1,000 cases of measles, we've just spent $30 to $50 million just on contact tracing, outbreak management, and trying to do the right thing. I really wish we invested that in vaccines. That would have made it a lot easier for all of us.
Heidi, you have talked a lot about language and how language of the public health community has been wrong, that we've been throwing scientific facts at people and not really communicating to people directly. What do you see as how the public health community needs to change in the way they approach it, in the way they think through the messaging and language?
I'll just add one quick, just for some context on the measles. We have 130,000 cases of measles in Europe right now. Well, over 125, I just haven't checked the... So just to put it in perspective, and we had 83,000 cases in the 2018. I mean, a lot of it was, this is the broader Europe, not just EU countries, like primarily in Eastern Europe, but yeah, just to put some context. I'm not saying 1,000. What concerns me in the U.S. is the trend. We're kind of, I don't want to say used to managing that much, but it's pretty bad in the rest of the world. So for those who are going to Europe in the summer, get your visa, get your measles shot. I think that one of the things I saw during COVID in particular, and I hate to generalize about anything. So I think, clearly there's some communication that's better than others. But I do think one of the things that I feel like we've been missing is making our message, and not just our message, our engagement, relevant to people. It's not just simplifying it. I saw during COVID a lot of effort from the scientific community to take kind of pretty complicated things, particularly around like mRNA and some of the new ways of making vaccines. And I mean, I thought the public was pretty amazing in the way they got with the program and self-testing. I mean, I never thought I'd have a taxi driver in London saying, just got my lyophilized test, or my, lateral flow test. I just got my lateral flow test. I was like, or did it myself. He was quite proud of himself. But I mean, it's the way people were talking. I mean, it was a huge opportunity for us to kind of get it in people's language. On the other hand, there were some very complex things, and right now we have there's a lot of public anxiety, more even than during COVID about mRNA, but that's another topic. But I think that instead of trying to just simplify pretty complicated things, and a lot of parts of the public really don't need or want that. What they want to know is why should I, what is it, how is it going to help me? Or how is it going to help my kid or my family? And I think that's where I just had a Nature article, which I know I'm jumping the gun here, but that came out a couple weeks ago called Science's Big Problem is loss of influence, not loss of trust. We still have pretty high trust in scientists, globally, actually. But when you start to put it in the context of who else people trust, then you see that it's all relative, and that's the part that we need to think about when we communicate. Who else are people trusting? And the biggest globally is family. And it's striking. And the next is GP. GP and family generally have higher trust than science. But on the other hand, a lot of people say they trust science. They just have a very different notion of science. There are some people running this country who, yes, if you say, do you trust science? They're going to say yes. But a different notion of what science means. So I think we have to make it more relevant and figure out ways.
What seems questionable with what you just said is that family, so the question is, where does family get the information to share?
Well, exactly.
They're getting it from social media, they're getting it from distorted, they're getting it from
Exactly.
disinformation, misinformation. So how do we, if the family down at the local level, you're really talking about not hierarchical, up versus down.
Yeah.
How does the public health community break through if the family is the most important source of trust?
Well, I think, and it's absolutely true, I mean, there's family, and it's hard when you say, we absolutely see that people who are more frequent users of social media are more likely to distrust vaccines. That's clear. But which platforms and how and what the content is, I think we have to be a little careful about just chucking social media or blaming social media for everything, because part of the reason that's the case is we're not using it enough. We're not putting enough good content online. And to me, to get to reach those families, we need to engage much more with where people are. We've been very shy, hesitant to get into the social media space. It feels very toxic. It is very toxic. I myself have tried to avoid being on it. I've had my group or people in my group because I've had enough threats of all kinds. And so I think we need to think, and in different situations, understand who people turn to. In the Philippines, it's all about Facebook. In Japan, it's all about Twitter. You could shut down an HPV program because of Twitter. That's what happened in Japan. But we need to look at because we can't take it to an individual. We can, in your doctor's office, recognize, and if you've got a resistant person, try to find some family member who might be a little more open that will help. It's just we need to take that ecosystem approach. In Africa, it's religious leaders. They rank above everybody, except in Ghana. That was the one country that had science above religious faith. And we've got some, a lot of this evangelical leaders who are very, very influential. And maybe some of those, they're not necessarily against vaccines. So we need to understand who are the, and I don't think we should assume that it's the scientists, and we'll stop here, or medical doctors who need to do that work, because, you're already over the, I know there's a lot of scientists without jobs. Maybe we want to get communication training going, but I don't think that, I think we need to get more partnering, more collaboration going to make that feel like a safer space, especially with AI now. If we don't get on board with that, we're rolling the red carpet out even further for this questioning.
Grace, do we know anything about how pharmaceutical companies are looking at this distrust, and are they hesitant now to go into new vaccine exploration, and what's the impact of that going to be?
Well, I think that's one component of it. We're hearing different things. I think it depends on whether you're taking the short view or the long view. And as we know, vaccine development takes a very long time. So I think most people are still taking the long view, although certainly it could potentially impact the market, the acceptability of vaccines. It could impact the market. It could impact the return on investment that any pharmaceutical company could gain from investing in this. And as we've said from the outset, even just getting industry to invest in prevention versus treatment, the incentive is not there just at baseline. So I think this cannot help. On the other hand, I'm not giving up hope. I will just say that one of the things we say in quality is every system is designed to get perfectly designed to get the outcome it gets. And so we have to really be thoughtful about how we're designing our systems and processes. And I would say that is a call to this audience in particular, to think about how policies can really impact the outcome here in this situation. So when I think about my biggest worries, I am worried about the innovation pipeline. I do think that there are many ways that it can get disincentivized, of which hesitancy, which is not a monolith, is one of those areas. But I also think it can be in the way that we're thinking about, I'll give a couple of examples. One is we all would love a universal flu vaccine. We all would love a universal COVID vaccine. And I also have enough humility to know that I don't know the best way to get there. I know that there's many things out there that could get us to that answer, and being able to allow that scientific innovation and that spirit to really guide us, I think is where we need to invest. And I'm not saying that this is true for everything that I do in life. I know where I want to go. I'm not always sure that I have the best answer for how to get there. So I look to the people around me and the expertise around the table to help me get there as part of that. That's one piece of it. I think I want to also just comment on the regulatory piece. I think we're going to have to really think carefully about making sure that, for example, the discussions around placebo-controlled trials being a really important one, of which the vast majority of our vaccine trials have been placebo-controlled. I can even point to one that was focused on vaccine safety, the rotavirus vaccines. 70,000 children were enrolled in that trial, in a placebo-controlled trial. And I think to demonstrate safety of that particular vaccine product in that time. I do worry that flu and COVID go quickly, so strains change on a yearly basis, and that's why we're always looking at it. And the impact of requiring a placebo-controlled trial that could take 1 to 4 years, we might have a perfectly well-tested vaccine that is completely useless in 4 years. So I think we just have to do that. It's a balance of making sure it's practical and can help us achieve the goal that we want, and also adheres to the best scientific principles. So that's from a regulatory standpoint. I think the third place I'd say is, obviously transparency. So I'm a huge fan of federal advisory committees. I'm a huge fan of making sure that the public has view into the way decisions are happening. And I can't underscore that enough. I think there are small ways that could, in the future, collectively potentially impact the public's ability to see what's happening in decision-making, whether that be through federal advisory committees and ensuring scientific independence of these committees, whether it's through not having open meetings and making decisions behind closed doors, and whether or not it's allowing the public to actually comment on rulemaking, which I think...
You sound critical of the way in which it's being done.
No, actually, I just am thinking that it's really important for us. So the one thing I do know, there are many decisions that happen every single day. And I know in my everyday life that people aren't always going to agree with my decisions that I'm doing on behalf of our work for our institutions. Well, I'll just say for patient safety in this instance. At the same time, I think that the way we can make sure that the best possible decisions are made is to open it up to public view so that people can have a conversation like this, an open and honest conversation in public view that allows people to understand how decisions were made. They can disagree with the decisions, but at least if they're not disagreeing with the process of how those decisions are made, that's where I think the consistency is needed and the transparency is needed. So those are the areas that I would just emphasize. Independent of the decisions in themselves, I think the process is incredibly important. So hence I go back to systems and processes are so critical to how we get to the outcome that we really desire, which is really the health of our populations. And I think I truly believe that's a shared goal. So I'll just pause there. And maybe I'll make one other comment, since we're at time. But I just want to make one comment about what you mentioned about we exist in, at least from an improvement standpoint, we talk about it as a socio-technical system. So we're often really good at the technical, which is the science. And I think that's incredibly important, but it's not sufficient. It's necessary, but not sufficient. And I think when we're talking about navigating huge changes, it's both the social and the technical that are required in order for us to enable that change. And so I think we historically, as scientists, have wanted to lean on science as the way to make change happen. And I think that's not true anymore. I think we just have to acknowledge that we have to think differently about how we approach what we want to accomplish together. And we can only do that not just standing in the science, but it has to be a combination of both.
We talked about ending our part of this conversation by being optimistic and having some optimism amid this sea of distrust and morass. So what are you optimistic about when you look at the current situation of vaccines throughout the world, the hesitancy, the fear, the confusion, the misinformation, mistrust? What are you optimistic about?
Do you want me to?
Try. You tell me first.
Well,
are you optimistic?
Yeah, I at the end of my book, Stuck, it was a bit of a play on Bill Gates, but I said at the end of the day, I'm a patient optimist. He always says he's an impatient optimist. I think you need to be a patient optimist, but not always patient. I think it's really, really important to keep a global picture because there's a lot of great things going on in the world. And there's a huge repercussions of what's going on in the US for the rest of the world, no doubt, particularly in my broader global health work with HIV, TB, and in other things, but globally. On the other hand, I've been in China, Japan, India in the last few weeks, and Singapore, and the enthusiasm for science, the investments in science are huge in some other countries in the world. Africa is taking as hard as it's been to see budgets slashed left and right. They're using this opportunity, which already started because they were so let down with what I call the phantom cargo of COVID vaccines. There's this huge energy around building sustainability, local capacity, both in making vaccines and in training people and in getting things going. So my hope, my optimism is that sometimes it takes a system shock to get new things happening. I think, I'm not happy-go-lucky at all, but I just think for my mental health, I need to be focused that. And also, I see in the Vaccine Confidence Project, we started with a team in London, but it's more of a consortium over those 15 years. And I see this consortium of younger scientists and researchers who, they just give me hope.
Are we in that period of shock?
Oh, I couldn't think of a period of shock outside of previous world wars or something. It's playing itself out in different ways, but yeah, I think it is a huge shock. I think it's also the pace and the uncertainty. I think the uncertainty is probably the hardest thing for everyone in the world, because you just got to go with what you have and keep your head down in a way, keep your head up, but also not lose sight of what you can do within the situation you have.
Grace, what are you optimistic about?
Well, I just came back from a scientific meeting where somebody was discussing sort of the next generation of vaccines. And I have to say, I went to that talk and I sat and I just enjoyed myself because I thought, oh my gosh, there might be a way for us to continue to do even better in terms of preventing transmission in addition to protecting high-risk individuals or individuals from serious complications. And the other thing I'll just highlight about vaccines is we tend to be very focused on the illness it prevents today. I have to tell you, especially as we're moving into the adult vaccine world, the impact of preventing infections is far greater in that I'm now appreciating sort of the long-term morbidity and mortality 12 months to 5 years later, the differences we're seeing because of the complications, whether they be pulmonary, cardiovascular, or other, that actually, especially for older adults, a particular infection can really tip them over to really a lower baseline. So I think that we are undervaluing the importance of vaccines in both acute infection as well as in chronic disease prevention. And I truly believe, and I'm optimistic, that eventually the science will allow us to catch up to that, to be able to incorporate that in our recommendations and decision making. But then I'm going to end on two different quotes. So I go to these two whenever I need to feel like I'm not going to call it denial, but I'm just going to say that when I feel like I need a moment. And one was actually I went to a session. It was one at Stanford where Chelsea Clinton spoke, and she said that hope is a moral choice. And I really believe that. And when she said that, it really resonated with me. Because I think it is a choice we have to make every single day. It's not easy. I actually often feel despair, but I have to lean on that as the anchor. And then the other is one by a reproductive rights advocate named Loretta Ross, who said, when the world's a mess, just grab a broom and sweep where you are. So when things feel completely chaotic, out of control, and uncertain, there's at least some things that are within our control that we can do. And so being able to move forward and be able to address that, I think, is what we can control and is something that all of us should be doing in the collective. So I'll end with that.
Heidi, you want to say something?
Yeah, just on the hope is a moral choice. I'm leading this new Lancet Commission. Well, it's not so new. It's taking longer than I thought, but called The Emotional Determinants of Health. And because I really feel like it's the biggest missing piece in the portfolio of determinants of health. I think social determinants is not honestly titled. It's really socioeconomic determinants, and there's different commissions. But the emotional determinants, we've seen loud and clear with vaccines, and we have a mix of neuroscientists, evolutionary biologists looking at why we have emotions in the first place, to physicians and emotions, because I think we've been very focused, increasingly paying attention to patient emotions, but as one of the doctors in the commission said, it was almost like COVID gave us permission to have emotions because everyone did, but when you're trained to have detached emotions, so we've got a whole section on physician emotions, and the other space is on AI and technology and emotions, which touches a bit on the what you were talking about, social and technology. We call it STS, society, technology, and yeah, science, I guess. But at any rate, if anyone's interested in it, please let me know. But hope is a really powerful lever that we've seen. We've got research on where do we have evidence of specific links like stress and cardio, but there's also people working on hope and wound healing and how it affects progression of disease. I mean, clinical evidence of some of these. So anyway, it's emotions matter.
Thank you. Thank you very much, panel. We'll now take questions from you in the audience, and here's one here and back there.
Oh, thank you. So I have two questions. One's a U.S. and one's a global. So the first to you, Grace, is that it's just having been in conversations with some of our pharmaceuticals, they're absolutely petrified that RFK is going to take away the liability issue waivers for vaccines. And so I'd like to get your feeling about the impact on, I mean, you're very excited about the innovation pipeline, but what will happen if that liability waiver goes away? And then the second question to you, Heidi, is Gavi and the fact that the U.S. has pulled out of Gavi, and also Gates' announcement that he's sunsetting the foundation. How do you think that's going to impact vaccine? Because they've been a really big player. Thanks.
Just 2 seconds on the liability because I was in UNICEF and we dealt with a lot of procurement. Before we had the change in the liability, I mean, this was like 25 years ago, we saw that as companies got more and more anxious about liability, we were losing producers. I mean, companies were shutting down, and that really saved us from a global supply, having the current system. But anyway, so there was a huge impact, and I mean, I look forward to your thoughts on that also, Grace. But on Gavi, well, the replenishment is next month in Brussels, so I'll have more. But it's not just the U.S. Across Europe, all the bigger donors for Gavi are all pulling. I mean, there's such a massive Europe. Everybody is worried about a war. I mean, everybody, and heads of states have been gathering, and also they feel like the U.S. is not going to help them this time. So everybody's upping their defense budgets. Global health budgets in general have been coming down slowly. So it's not just the U.S. I mean, the U.S. was a huge funder. It's going to affect it. They're going to have to scale back. So we'll see, what can happen. They may have to pull some of the longer term resources to short. But that's going to be a conversation next month. In terms of Gates, there's a lot of, I just came from the foundation from last week, and there's a lot of enthusiasm internally. They're really thrilled that there's this new infusion of funds. I've had grants in both at UNICEF and now from the foundation, so have been very engaged there. I mean, it was already from the beginning known that it was going to have a very time specific, but it was going to be, I think, 10 years after Bill died. But he, in the context of what's going on in the world, pulled it back and invested more now because he saw an acute need in the world. So I think 20 years is short but long. I mean, I think it's. There was a lot of positive optimism about that decision. So I can only hope that it can help, particularly during this acute time.
And I'm going to try and be very brief, and I'm happy to stick around afterwards, but there's two programs you're speaking about. One is the Vaccine Injury Compensation Program. The other is a countermeasure injury compensation program, both administered by HRSA. And the idea is that they have these tables where, the reason they're established partly is liability. I mean, partly it's fairness and justice, in part because I think of it as a way to there are some side effects of vaccines that can have significant impact on individuals, and for vaccines that are incredibly important for society and populations as a whole, I think there is an acknowledgement and a recognition that that trade-off exists, and as a way to make it to address that issue, I think that's part of the reason why this compensation program came into place for injuries that are on the table. I would say it could go in either direction. I think the one thing about the compensation program is that it fairly provides resources to individuals who may have had a vaccine injury where the data and the evidence are indicative that that is related. Maybe not even causal, but clearly associated. And I would also say that it can go in the other direction, I think, where potentially there could be an expansion without sufficient data or evidence. And I'll just highlight that, I think we'll talk afterwards, because I think it could go in either directions. And part of it has to be with the reasons that people use that program. From the industry perspective, though, I think it is critical for sustainability and for stability. So for those two reasons, my hope is those programs would not be affected.
Yeah, I'm with you. Yeah.
Who else has a question? Here and there.
Thank you so much for the terrific conversation. My question is for Grace. Access to vaccines economically and logistically has really depended on this scaffolding that we've had around ACIP. First, that its recommendations have become requirements for commercial health insurers to provide first dollar coverage. And secondly, that CDC generally defers to the committee in its own recommendations around vaccines. So both of those, as you well know, are currently under deep threat now. And my question is, how do you size up the commitment of commercial insurers and Medicaid programs to providing first dollar coverage if it's not required or CDC recommended?
Well, thank you for calling out that ACIP is unique in that it has some statutory requirements, one being VFC, the other being tied to the ACA. And I think that it has been important. I am worried and concerned about what could happen. And I think that it's already a patchwork. Our healthcare delivery system is already such a patchwork of coverage, of accessibility, of affordability. Like I worry a lot that the people who are going to suffer the most are going to be the individuals who are trying to retain access to vaccines. I mean, I've had people come to me and say, maybe I should just get all my vaccines now in case none of them are available in the fall. And not joking, because I think there's real concern that, and some of these vaccines, you know, in the old days, childhood vaccines used to be $10, $20. We're talking about newer vaccines, newer technologies, really, you know, almost like precision vaccines is what I might say. We're getting better and better at it. And so the cost is higher than it used to be. And so if not covered, I can imagine there would be a significant proportion of the population that would go unprotected, not because they didn't want it, but because they wouldn't have access to it. So I think it's another aspect of stability and sort of fundamental access to health. It seems like that would be a really important one to just highlight and make sure we have ongoing transparency in both making sure that the committee's work remains intact, the committee remains intact, and that we can get to a point where that is no longer a concern.
Final question here.
Thank you. I was always under the impression that the issue had been the user, the individual emphasis in our society as opposed to the societal. But you're saying that in Asia, in Singapore, and in Hong Kong, this is as big a problem as it is in the US or even bigger. And it's just surprising, but I'm also concerned that we're losing the collection of all the data in the US.
Yeah,
going forward.
That's a very big concern. The issue I was talking about in Hong Kong and Singapore was pretty specific to this older population and what we were a bit surprised about, because in general, vaccines are pretty good with uptake. I mean, for childhood vaccines. I have to say it's changing. It's changing in places that typically have had higher confidence. It's kind of eroding at the edges. And one of the reasons I think this has happened is before COVID, there were these pockets of conversations that were more parents or specific, maybe around HPV vaccine, maybe around shingles, I don't know, just conversations, but they were clustered. What happened in COVID is, and if in our nationally representative samples, say between like 40 and 65, people weren't looking for information on vaccines. They just were taking them for granted, and they had no idea. The number of people who said they had no idea there were even questions about vaccines during COVID, everybody, particularly in that age group that wasn't before, started going online looking, and it's like the world has bit the apple and the floodgates are out. So I think it's really, I'm not saying it's creating refusers so much, but there are very few people in the world now without some questions that they didn't have before. So I think that it has surprised me in Asia that there's more. It's not the same as here, particularly around childhood vaccines. I think the bigger issue here is, in terms of sentiment, is more childhood related. Maybe I'm wrong, but I think with adults, as you said, more access. But we really need to, each country, look at their situation.
Thank you for joining us. It's clear that we could talk about this issue from now till midnight tonight, but thank you for coming and joining us.